Good evening, everybody, and welcome to this another web-based session. This is essentially, as we said, this is from Apollo Gleneagles Hospitals, Kolkata, and courtesy this current scenario, uh, we have taken recourse to this web-based teaching, and because our students said that there are other people who are also interested in joining and kind of interacting with us and helping us also learn, we thought that we will use another portal, and this is the portal of HCP, which is healthcare professionals. And this is the first time that I am trying to do this on their portal, and let's see how we go about it today or this evening. We have Dr. Anisha Day. She is one of those passionate pediatric anesthesia person. She loves putting children to sleep with an assurance that they will be up and about after the procedure is over. I'm very thankful to her to be here this evening.
Yes, sir. Thank you very much, sir. So good evening, doctors. Good evening, everyone present here. HCP Forum welcomes you all for the first webinar of the anesthesia web series we have planned with Dr. Sengupta and his team. So just to give you an introduction about HCP Forum, this is a new forum which has been developed. It is a unique online platform for all healthcare professionals. It is meant to connect, it is meant to network, academically strengthen yourselves in your respective fields of specialization. So one of our core interest areas is this web-based lecture series. And as you know, this is a pandemic situation where we are forced to direct ourselves to this online format. So I'm honored to have this mastermind, Dr. Sengupta, behind this webinar series, who actually needs no formal introduction. Sir has this academic inclination, and I know him as an eloquent orator. So he is the chairman of Kolkata Anesthesia Academy, along with his professional achievements. I don't want to go into those things. So this is an academic endeavor taken up by Kolkata Anesthesia Academy along with HCP Forum. And this journey will continue in collaboration with Kolkata Anesthesia Academy under the able guidance of Dr. Sengupta. So we are pleased to have Dr. Dey with us along with Dr. Sengupta. Over to you, Dr. Sengupta. I think Dr. Anisha is also
Thank you. And before we start, I think I need to flaunt what I'm wearing. This is essentially because if people have been following my greatest passion, which is not anesthesia, not anything else other than football, and the club that is the dearest to me for a long, long time. So we have won the cup league after 30 years, and which is why you will find the same jersey, I think, which Ian Rush wore 30 years back. I'm with it tonight. So all the best, and go ahead, Anisha, with the basic principles of neonatal anesthesia.
Yeah, thank you. Good evening, everybody. Learning, as we all know, is a dynamic and a two-way process. Although the virus has taken a huge toll on us, it can never stop us from learning, unlearning, and sharing our knowledge. I would like to thank the organizers for creating such a wonderful platform for us. My sincere thanks to Dr. Shoikat Sengupta for giving me this opportunity. Neonates, as we all know, are neither small adults nor small child, right? So they are very tiny creatures, vulnerable, have very dynamic physiology, at a very high risk of developing all anesthesia-related adverse effects, and they belong to a very high group of mortality rates. But we cannot forget that they are fighters. Although they desaturate very fast, become apneic very quickly, develop sudden cardiac arrest, they are also easy to revive. So the key of success is constant vigilance, rapid recognition of any events, swift interventions. Yes, a full-term healthy, normal birth weight baby with no comorbidities exist, but unfortunately, they don't usually come to us. Hence, our neonates may be low birth weight, premature with associated cardiac and congenital anomalies, and disturbed immature physiologies and anatomies. So our approach has to be a little different from the grown-up children. This topic is itself vast, very difficult to summarize in such a short time, but I shall definitely try my best. We will not be discussing in details the anatomy and physiology here, but concentrate more on the basic principles and practical solutions. This would be our roadmap for the next 30 to 40 minutes. First, let's begin with prematurity. Those of us who have handled at least one child weighing around, say, 750, 800 grams, we understand how difficult it is to handle them. So, what is prematurity? It is defined and classified on the basis of gestational age. The cutoff is 37 to 38 weeks, 6 days, beyond which it's full term, before which we have the premature babies. It may be severe, moderate, or borderline. As per the body weights, the low birth weights are less than 2.5 kgs, and the other extreme is extremely low birth weight, less than or equal to 1 kg. The normal levels are between 2.5 to 4.2 kgs. One of the most significant problem among this population is apnea. So what is it? Apnea is defined as cessation of respiration for more than 20 seconds alone or less than 20 seconds with accompanying bradycardia. That is a reduction of heart rate by 30 beats per minute of the basal level, along with cyanosis, pallor, or hypotonia. It is maximum up to 12 hours post-operatively and may continue up to 48 to 72 hours. Hence arises the question and safety of RSI and opioid usage in them. However, there is prophylactic treatment options with caffeine and aminophylline in these babies. Among other problems, we have bradycardia. Hence, we should prefer cardiostable drugs, use atropine pre-operatively, and avoid hypoxia, hypotension, acidosis as far as possible. They are also prone to hypothermia, hence the thermoneutral ambient temperature of 34 degrees should be maintained to prevent excessive heat loss. They are also present with sepsis, for which adequate antiseptic measures needs to be taken. There may be hyaline membrane disease, PDA, hence proper precautions are vital. Handling glucose is also very poor, especially in the first 2 days of life. Other than these, blindness and lung injury due to oxygen toxicity are major concerns. Next, we go to thermal regulation. We all know that neonates have a large surface to body weight ratio, reduced subcutaneous fat, underdeveloped ability to shiver in response to cold, greater body water content, but they have a specific feature of non-shivering thermogenesis, which I'll just discuss in my further slides. The normal temperatures, a full-term baby, somewhere around 36.3, 36.5 degrees Celsius. Environment temperature, 32 to 34 degrees Celsius, and preterm around 34. Hypothermia may be mild, moderate, severe. Severe is less than 32 degrees Celsius. Now, neonates lose heat mainly by these 4 processes: conduction, convection, radiation, evaporation. Now, a few words, what I was just talking about, non-shivering thermogenesis. Now, when a baby is exposed to cold stress, the glucose is utilized to produce heat. This activates the brown fat lipolysis, leading to conversion of the brown fat to glycerol and fatty acids. Now, if we allow it to go on and on and on for a prolonged period, the glucose store actually gets depleted. And the results are metabolic acidosis, peripheral vasoconstriction, and aerobic lipolysis increase. Hence, these are all detrimental to the body. So what are we supposed to do? So we can use certain things to prevent the cold stress in newborns in the OR, like using warming mattresses, warming, humidifying the inspiratory gases, save the volatile agents at 36 degrees centigrade, warming the IV fluids, warming the blood products, the skin preparation fluids, the irrigation fluids, the radiant bear hugger warmers can be used, or hot air drapes and garments. Now the transportation. All of us might think just shifting the baby from a ward or then ICU to the NICU to the OT. What is it? Why is it so important? It is. A neonate should always be accompanied by expert medical and nursing personnel in incubators and isolates with heaters. If there is any ongoing IV fluids, drug infusions, it should continue. The monitoring should be uninterrupted and the transfer distance should be minimized as far as possible. Why? Because it has been reported that post transport mortality is almost 15 to 36% in our country. That's quite high for a mortality rate. The fluids, the electrolytes, the glucose, the spinal cord of neonatal anesthesia, what I feel, despite it being a very hugely challenging thing, a well secured IV access is quintessential in neonatal anesthesia. Since most of the surgical patients are kept NPM for long durations at times due to the surgical comorbidities and all, early administration of IV fluids is vital to maintain normal hemodynamics. Mostly it's the intravenous route, it may be peripheral or central. In very critical babies, we might need an intra-arterial line, and the intraosseous route is for the emergency resuscitation. Most common cannulation sites for the peripheral IV access is scalp, dorsum of the hand, palmar surface of the wrist. The sizes of cannula 24G, 26G as per the weight and the gestational age of the baby. Site and then it should be well secured. We should avoid air bubbles, drugs to be diluted, slowly pushed, and all the rest of the precautions to be taken. Central IV access sites commonly are IJV, subclavian, femoral, umbilical vein. It is accessible, but you need to avoid it because of the portal vein thrombosis. Disadvantages are there: malpositioning, infection, embolism, and thrombosis. So it is, if only it's necessary, essential, then go for it. In critically ill neonates, intra-arterial line. Right radial artery for the preductal and posterior tibial artery for the postductal. Sampling. Now what are the uses? Monitoring the hemodynamic status and biochemical sampling. Now we should be very careful regarding the heparin doses we use for flushing. Right? So the dose is 0.1 to 1 unit per ml dissolved in half normal saline at the rate of 0.5 to 1 ml per hour. Remember to change the saline, heparinized saline, every 24 hours and do not administer fluid or any medication through them. Now, fluid and electrolytes should be used very judiciously. Too little, we may cause dehydration, hypotension, poor perfusion with acidosis, hypernatremia, cardiovascular collapse. Whereas too much of it causes pulmonary edema, congestive heart failure, opening of ductal shunt, if any, bronchopulmonary dysplasias, intraventricular hemorrhage. So next we come to the most pertinent question. What is the type of fluid we use and when do we use it? So these are the recommendations by the APA guidelines. That is the first day, 10% dextrose. Day 2 to 7, 10% dextrose with or without electrolytes, sodium, potassium, provided that the urea, creatinine are within normal limits. Greater than day 7, isotonic fluids with supplementary electrolytes and minimum glucose. But in cases of preterms less than 1 kg, all babies not receiving feeds by day 3 start parenteral nutrition via the central line. Now the 3 pillars of fluid administration: replace the deficits, replace the ongoing losses, the third space loss, and maintain for the vital functions and growth. Continue the last 2 in the post-op period. Now, how do you assess? These are all same as other pediatric population. The important points are the core skin temperature is important, specific gravity of the urine and urine sodium levels are important here. And lastly, weight. Weigh each baby before planning for a blood administration, fluid administration, drug administration, anything. Now, first is the replacement of pre-existing deficits. Now, in the recent days, while we started following the ASA recommendations, the fasting periods have reduced. Earlier, like they used to be fasted from midnight and for 8 hours, 12 hours or more. Recently, we follow the guidelines, very less period of fasting period. So in that case, we have the lesser episodes of dehydration, hypoglycemia, hypovolemia in a term healthy baby. Mind it, These are all for the term healthy baby. Whenever we are having a critically ill or sick preterm, they will be dehydrated even with a very short NPN period.